We are getting to the surgical part with Professor Jacques Me from Switzerland, Geneva. He's professor of the University of Geneva, working at the Clinique Hirslanden, Clinique de l'exercice du sport, and he will talk, of course, about surgery.
Thank you, Philip. Thank you very much for the invitation. I'll be very brief, we're running late, and talking about eminence or evidence, I will give you the eminence way of living. Well, I have some disclosure, but I'm the greatest surgeon in the world, and this is very simple. I'm operating on all ACL, period. Thank you very much for your attention.
Jacques, do we have a change of plan?
Well, obviously, Philip, this is ridiculous, but this is the way things are actually communicated on social network currently, with very good science behind. While ACL is a very frequent injury in this part of the world, ACL is a very serious injury. That's been already mentioned this afternoon, and this is not all about ACL. When you have that type of injury upcoming, this is not a life-threatening. Well, when you are on the Ausbergkante in Kitzbühel, this is a life-threatening condition for sure. Well, if I try to wrap up a little bit what has been, or the criteria, the predictors that are, I would say, leading the indication or not on ACL, we have a couple of factors and requirements that you have to go through with your patient in order to decide it. Well, confounding factors are from the beginning there. Depends upon the population you're addressing. Depends upon your geographical location. If you're living in western part of Switzerland or in Switzerland per se, you will have a lot of alpine skiing injury, for example. You will have a lot of mountaineering injury. You will have a lot of water sports injuries, for example. It depends also of the healthcare system. And believe me, I'm running the world and I'm looking at the different people and, I will say, attitude in front of ACL injury, and it's very dependent of the healthcare system that the people are within. It depends as well on the density of care providers you may have, the specialty of the doctor, their training, the waiting list, for example, to get a consultation, a specialized consultation that could be with the sports doctors, that could be with a surgeon. All those things are very important. Well, we need to understand what is really ACL injury. There is, in women and in male, a different way of looking at it. In male, we have a peak of ACL tear or injury about 19 to 20 years old, a little bit longer then, and then the males start to degenerate a little bit. They don't do much, and they get less opportunity to get injured. For the woman, it's very different. The first peak occurs at 17, 19 years old, and at least in this country and in other countries, we have a second peak around 40, 50 years old, where the women are restarting, for example, to do alpine skiing with their children, and they got an ACL injury. Well, once again, definitions are important. We're talking about sports, we're talking about athletes. This is the definition we use to qualify a little bit the patient we are dealing with. Another thing, what we are talking about. Everybody's talking about return to sport, but what does it mean? If sports is biking, all my patients at 6 weeks post ACL tear or injury are biking again, so they are 100% return to sport. But this is not the point. Are they going back to practice? Are they going back to competition? Are they going back to performance? And this is, I think, still something we need to really carefully, I would say, investigate, especially when we are dealing with professional athletes. Well, which strategy? You have already looked, obviously, talking now about evidence. You know, evidence is a journey of humility. And even when you look at good and well-designed RCTs, RCTs have flaws as well. RCTs sometimes do not address all the problems you may have. And you have still to look critically towards RCTs when you are looking at a specific question. And we looked at that. And for example, in the RCTs and looking at the indication to ACL treatment, it's difficult to generalize. we always have one of the bias, which is a selection bias, which is the type of patient you are enrolling in your study. And this is something important. But all of us in this room, and I'm sure we all have a confirmation bias. In other words, we always try to favor what we believe is the best for our patient, and we have to, I would say, not be afraid to look at the counterpart of it and try to look at the best thing. Because there is sometimes a big discrepancy between science and daily practice. And this gap is sometimes very, very difficult to bridge. This is why we looked at some, I would say, design called consensus, and this is something that has been developed, for example, in Europe with the ASK Society, where we are really matching the scientific evidence, the strongest one we can get, with some clinical expertise by gathering together a couple of experts on that. With those consensus, well, can be extremely powerful to tackle one specific question and try to bring the best answer at the time given, because this is something evolving and this is not forcefully the absolute truth, but this is something important. Coming back to our criteria for decision making. Well, nowadays, ladies and gentlemen, we need to quantify. We need to measure. We need to look at all the aspects. Again, this is not all about ACL. This is all about the different things of the knee. You have to look at the bony deformity, you have to look at the tibial slope, you have to look at the ties and size and look at the laxity and look at the different associated lesions. This is something very important. And then, as you have seen, you will have to classify your injury. You can have partial ACL tear. We have seen a lot of partial ACL tear this afternoon. You may have isolated some, I would say it's becoming very rare, but you can have also associated lesion. The classification we're using is based mostly off the laxity, and especially the rotational laxity, because rotational laxity is a very important factor. And probably one of the best moments to measure this rotational laxity is after 3 months. 3 months post-injury. This is something important. Well, the group of Romain Zeil in Luxembourg even, I would say, sophisticated this type of classification by looking at the different factors, going from bone bruise to the associated lesion in order to classify the type of ACL injury you may have. Associated lesion. This is something extremely important. This is something that is more and more and more, I would say, frequent. ACL injury in this part of the world are more and more complex, and therefore you have to try to depict the best. Because still, this is something that is still true. If you let someone with instability or laxity going back to jumping or cutting activities, you may increase the number of associated lesions. But this is not only in the youngest. One example, 49 years old, event manager, playing tennis, snowboarding. She has been treated conservatively for a year with a laxity once again that was remarkable. And you can see that after a year, she has a meniscal tear, she has a lateral meniscus disinsertion, she had a lot of associated lesion. We looked at those concomitant injury, and we found about 80% of our ACL tear, once again in this part of the world, that were very, very, very frequently associated to the ACL tear. Once again, looking at the new classification of meniscal tear, this is not only a bucket handle tear or vertical longitudinal posterior tear, this is all the meniscal tear, including all the disinsertion and the instability of the menisci. And this is, again, shared by other teams in the world. You see that isolated ACL has become extremely, I would say, rare in the current practice of medicine. Well, what do we do with those meniscus? Well, those meniscus, most of the time, we try to refix them, we try to repair them. Why? Because this is important for the, I would say, outcome at 5 or 10 years. And if you save your meniscus, your functional result and outcome will be better 10 years later. That has been well demonstrated and for years now. About the cartilage, this is a totally different story, and I will not extend on that for the sake of time. But very importantly, if you want to go for a surgery, this is again not all about ACL. You need to see exactly all the type of injury you have within your knee, and with that you will fix what is necessary. And we know now that, for example, menisci are very important for the stability, the rotational stability. I'm coming back to this very important factor. Well, a few words on the MRIs for addressing the healing phase. The problem is that MRI will look at the continuity of your structure and your tissue, but that will not guarantee the functional stability. And this is particularly, I would say, relevant when you have an elongated one. One example amongst others, this is one of our mountaineer who was climbing alpine skiing. With this MRI, he has been said that he has no ACL injury, therefore he didn't need any treatment except a lot of exercise, a lot of physical therapy, but he was still complaining of functional instability. He couldn't resume any of his activity. And when you look into the joint, in fact, you have a continuity of the tissue, but this tissue is absolutely not functional. It's not holding anything. It has no mechanical features. And moreover, for the surgeon in the room, you will appreciate that, in fact, the tissue is not inserted exactly where the anatomical femoral insertion is usually. Well, I will finish up with that. Once again, a good way to look at that is to bring all the science, all the best science with the most robust one, and to discuss it, I would say, with experts from the different fields, including physical therapists, including sports doctors, including exercise medicine doctors, etc., etc. And we did this exercise a few years ago in Pittsburgh, and I just delivered to you the conclusion of this, I would say, huge work. First of everything, operative and non-operative are reasonable and decent treatment according, once again, to the type of ACL tear and I would say knee injury you have. Second thing, if you have meniscal that could be repaired, obviously that would probably motivate your ACL reconstruction. More we know about it, more we see that the bony morphology, the more bony problem may raise I would say, the risk of instability again or failure if you have an ACL reconstruction. Now, if patient has clearly instability that is reporting, it's probably safe to propose him an ACL reconstruction. By the way, ACL surgery has so much improved over the last 10 years that we have to pay attention by, again, looking at all those data at the time where we have to acknowledge that probably it was still a little bit experimental. Now, if you have a straight, plain activity patient, of course you have to start with a non-operative treatment. Well, to make a long story short, and this, I would say, statistics from Roman Sale match relatively well our experience. No, we don't operate on older patients. Yes, we do operate in the younger patient because very often due to the associated lesion and again according to the ACL severity. In summary, I would say today it's really personalized and individualized decision-making for sure, looking at functional stability, looking at the laxity, looking at the associated injury, looking at the type of patient you are dealing with. This requires serial evaluation, serial measurement versus operative versus non-operative treatment. Once again, both approaches have their place in our therapeutic tool, but the patient must be followed up. And I totally agree, there is no emergency except for specific cases, and you know which they are, to really rush on any surgical treatment. With that, I still invite you next year in Prague for the ESCA meeting, and I thank you very much for your attention.
Thank you very much, Jacques.